So we are in week 7. I really appreciate all of your patience today. I know it's hard when all of a sudden instructor has some personal things going on in their life and we have to combine and work together. But that's what nursing is all about. It's all about being a team. So I appreciate all of your patience with that. I'm going to be doing a Kahoots today instead of a PowerPoint. Over the Kahoots, I'm going to tell you these big concepts that you need to know in order to be successful and understand the material. So this week is chapters 46, 47. It's cerebral dysfunction and the child with endocrine dysfunction. So it's about the head and all of those hormones, right? Endocrine. So we're going to look at that. There is a quiz, if you notice, scheduled for next week. There will not be a quiz next week. Next week is Memorial Day. So Monday classes don't get a quiz. So all the classes don't. So your quiz will be on week 9. Next week is week 8, okay? And that will come out in the announcement just to let you know. That means your week 9 quiz is going to be on week 8 information, okay? So that's just for you all to know. There's a discussion question and there is a CJ Sims. So that's what you have to do. Remember, next week is that pediatric assessment assignment. If you have not put in what your diagnosis is to your professor, I highly suggest it. We do that so we don't get all of the same thing. we like to hear new things. We like to be taught things. I know that some of my students are doing some things that I'm really excited about and also to learn about. So pick something that's near and dear to you, something that you had, your child had, your brother had, your cousin had, something. Tell me, find something that will interest you. Remember, there's a paper, there is a form, which is the whole big assessment. The end of that assessment, your most important. That is talking about you're a theorist, and it also talks about making nursing diagnoses, okay? So just to know that it is due next week, but it is 6% of your grade. So try to start it. I know that I've told my class, turn it in early. I'll be looking at it, trying to help you get ready as you go on forward into your higher level degrees, because I know many of you have already planned to go on. So with that being said, we're here to help you to learn APA, how to
Betty,
put out those things.
Betty,
Yes.
Tamia has not moved. She's still testing.
Did you move her or you want me to?
I I've been trying to get her to move. Has not accepted the move yet, but she is still testing.
Do you see her on the screen? Oh, there she is.
I
Yeah, she's
just have to
She
did you
just
just
finished.
okay.
now. I'm submitting it.
Thank you very much, Tia. All right, let's go ahead and let's do the Kahoots. Who feel like winning a Kahoots today? I'm going to try to explain these questions in a manner that you're going to be able to apply it in other different ways. There are 49 questions. I'm going to go on as far as I can. I know it is now, 9:37 my time, so I think I can get it in.
Okay.
What I will be doing is because there is a PowerPoint that goes on with today, and I do have a recording of me talking with this PowerPoint. So I'm going to be sending you that recording too, so that you can look at the PowerPoint or listen to that recording, whichever way that you learn the best. Who else is going to come and join me today? All right, let's get started so we can get in this information for you. So it's cerebral and endocrine dysfunction. Week 7, it's going by quick. Growth hormone is administered by what root? Now, this is the week of endocrine. So, where's the growth hormone? It's in your pituitary gland. You have your anterior and your posterior pituitary gland. One regulates fluid, and the other one will regulate your growth. And if you're this short person and everybody else in your family is not, we can give medicines. And it's just like being a diabetic. It is an injection, subcutaneous every day. So it really takes a commitment from the child and from the parent in order for this to work. And what they usually do is they'll continue the hormone up till they stop growing less than 1 inch a year so that they'll receive their maximum height that they possibly can. Highest priority for a patient diagnosed with syndrome of an inappropriate anti-diuretic hormone. Well, what is this? Let's look at the words. Inappropriate means something's wrong. Anti-diuretic, against urinating, right? Against diuresis, and it's a hormone. So you're getting too much of no urinating hormone. Literally, that's what it says. So if you're not urinating, again, posterior pituitary gland, that's also where diabetes insipidus is, which is the opposite of this one. It's all about intake output. Are we taking in? Are we getting out? And we're monitoring weight, daily weights, very important also. Which of the following are signs of an inappropriate anti-diuretic hormones? What of the following signs are? How would you know that you have too much inappropriate anti-diuretic hormone? Inappropriate, too much anti against diuresis. And that's how you take this big word and go, oh my goodness, what does it mean? And break it. So if you're not urinating, you're not going to have a urinary output. Excellent. How do we monitor it? Intake output, daily weights, and of course, we'll be doing salt restriction, fluid restrictions on this child also. Again, that goes with retaining fluid, any age. What is important to cover when teaching the family about polypropyl? It's also called PTU, and this is used for hyperthyroidism. We've all have heard of synthroid, right? That's for not enough hormone. Well, this is when you have too much. It blocks the amount of thyroid hormone that's being made. Now, one of the things with there's two medicines for hyperthyroidism, they both cause leukopenia, which means you don't have enough white cells. What does it mean when you don't have enough white cells? That means you don't fight infection. So, fever, sore throat could be a side effect. And we should tell this family and the child to call the doctor if something like that happens, just to rule it out. Is it an infection or not? A multi. An initial sign of diabetes insipidus. So remember, it's the opposite of the inappropriate anti-diuretic hormone. It's inappropriate diuretic hormone. That's the opposite, right? So what are you going to see? We see this in infants where newborn babies, they just drink, 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 and they're never satisfied. Give them a bottle of water and they're happy. And there's two signs. Now, there's two types of diabetes. We know one has to do with the pancreas and insulin, right? And then this is diabetes, which has nothing to do with blood sugar. It's all about fluid balance. The signs and symptoms are similar. Now, DI, diabetes insipidus, is you're thirsty and you urinate a lot. If you had diabetes mellitus, you're also hungry because you're not using your carbohydrates. So you're hungry. So you would have 3 Ps, polyphagia, polyuria, polydipsia. But in just diabetes insipidus, it's only about fluid. So you drink it and you urinate it. Those are the two signs. Multi. What are the clinical manifestations of juvenile hypothyroidism? I mean, I don't know if you've studied it in med surg yet, or you just did, or you're very close. Signs and symptoms are different. But what's the difference between children and adults? Well, children still have to grow, right? And part of the growth, one of the hormones they need is a thyroid hormone. So you're going to have the dry skin, constipation, cold intolerance, but you're going to have decreased growth because you need it to grow. As a newborn, if you don't have thyroid hormone, you're going to be cognitively delayed. We need it for our brains as young infants and throughout childhood, okay, to grow and for their brain. A child has a simple febrile seizure. What education would you provide to the parents? Febrile seizures are common. They happen in from normal temperature, 20 minutes later, they have 101. So it's the rate of rise that creates a seizure to happen. You know, my oldest grandson had this, and I know that his mother, forever and to this day, carries a thermometer and always these antipyretics around with her because she does not want, to have a febrile seizure again. And he only had one. So, one of the things about anyone with seizure is all of that protecting them safety, protecting the airway, turning them over to the side, allowing them, if they vomit, for it to get away, have suction just in case to suction it up if it gets that far, okay? And then if there's anything around them when they're moving, protect them from injury. And any tonic, clonic, grand mole type thing, these are those safety precautions are the biggest thing because you can't do anything else. You can just watch them. What type of seizure is when the body's jerking, you're foaming at the mouth, and the child is rendered unconscious? This is what we call that major type of seizure. Now, there are seizures that are caused by fever. We have the absent one where they have these blank looks. And then there's the tonic-clonic. That's the other name for grand mal today. So that's the arms and the legs are going. Usually they're incontinent. They're usually foam at the mouth, maybe vomit, so that's turn on their side. And they're usually postictal, where they don't really remember and are a little bit cloudy when this is all done. What notable sign may indicate increased intracranial pressure in an infant? What would happen if your head hurt, was full, and you had this increased pressure? It's part of it. Now, the one thing about infants, they have these beautiful fontanelles. And increased intracranial pressure would be a bulging fontanelle at rest, sitting there, asleep. It would be bulging. Most infants will bulge if they're crying loud enough, okay? They also have what we call this high pitched cry. And if you ever get to the point where you work in the newborn ICU, you can walk into a room and a baby will be crying, and you will know this child is neuro. That cry is this higher pitched, and you do hear the difference. All of the following increase intracranial pressure except what? Taking care of these children in the intensive care or the ER urgent care, we need to know how we can minimize increase in that pressure, right? And the only thing that does not bother it is an elevated heart rate. Okay. If you touch them, suctioning, you're gagging them. Absolutely, it causes it to increase intracranial pressure. Coughing, any type of fluid overload always is increased intracranial pressure. But bradycardia, tachycardia does not affect the pressure in the brain. Findings can you alert you to a head injury getting worse? Now, I worked in the ER the last part of my career, and we used to have children always in sports, sliding into third base, hitting their heads and being knocked unconscious. How would we know that it's just not a normal head that's been hit, right? That's it's getting worse, maybe bleeding going on. And it's all about they start asking, so was I safe? Did we win the game? And they keep asking over and over again. It's that mentation, that's orientation. It's they're just not understanding. And then if it gets to the point where they're vomiting and they have headaches that wake them up, that's when your head injury is really getting severe. But first thing, change in orientation, level of consciousness. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? You know, one of the things I did is I was always a primary trauma nurse in the ER, which means I used to get children falling off second story balconies. And I wish it was only one or two. It was quite a few, four or five. And the first thing look at as healthcare professional is we want to look at those pupils. We want to see, are they equal, are they reactive, or are they dilated and they're fixed? They're dilated and fixed. It is a medical emergency. It means that there's damage in the brain stem. And that's the back of their brain. There's so much swelling. That means your heart rate, right? Your vital signs, your temperature, all controlled by your brain stem. So it is serious. Neurological emergency. They need to remove it, somehow. Call neurosurgery now. So, what medication can be used for a child with cerebral edema due to a fall? Well, when we have edema, we use diuretics, right? Now, there are some specific to lungs or peripheral, but there's one specific to the brain, and we use it and it works really quick. Which one is it? And it's mannitol. Mannitol is specifically for the brain. In pharmacology, the other uses are renal failure and toxic ingestion, but most of all, anything with the brain is mannitol. Ray syndrome, what is it? So Ray syndrome is a condition, there's a metabolic thing, but what it is the children under the age of 8 should not be taking basic aspirin. They say it could cause Ray syndrome, which is extremely dangerous and cause child to be very sick. That is why when we are teaching our parents and children about fever control, it's always acetaminophen and ibuprofen after they're 6 months old. Then they can have it. So if you ever hear aspirin's being given, no, we will not. There's one case that we give aspirin, and that is Kawasaki disease. And we learned that in the cardiac chapter. Kawasaki, that vascularitis, it prevents the clots. That's why they use it. Febrile seizures usually occur in what? And it's somewhere between 6 months and 6 years. Sometimes a little lower down to 3 months, but usually it's about 6 months up. And again, usually febrile seizures. Parents are going to come in. Does this mean my child have epilepsy? No, it doesn't. Epilepsy is more than one seizure per day, not related to fevers at all. And usually they'll grow out of it.
Professor Bogart, there's a question in the chat about the last question.
Okay. Childhood hypothyroidism results in which condition? When we're done, we're going to talk about that because I can't see the chat right now. So hypopituitarism has to do with growth, right? Your anterior lobe of the pituitary gland deals with growth. That's the growth hormone, subcutaneous injection, right? There's also conditions that can be caused by not enough pituitary hormone, and that's called pituitary dwarfism. What was the question that you were trying to ask? I'm sorry, I couldn't see it.
It was me. I was just kind of curious about the Kawasaki disease. I know that they're allowed to have aspirin. Are you not worried about them getting like a secondary Reyes syndrome?
Well, they watch it really closely. They're also given intravenous immunoglobulins, IVIG, and the combination works really well. And if they're Kawasaki, they're in very close monitoring with physicians during the whole thing. They now are looking at, instead of aspirin, doing Coumadin. So it's one of those, what's better to thin the blood, a little aspirin, or is it that Coumadin? So it's something that's being looked at, but that's an excellent, excellent question. And, I've often wondered it, but, I've never, with all the Kawasaki I've never seen it go into Rey syndrome. And I've seen quite a few cases.
Good to know. Thank you.
No, thank you. How would you describe precocious puberty? Again, these are hormones, right? Between 10 to 12, you start with going through puberty, right? 2 years later, your menses. Precocious puberty is when you have boys and girls, they're going through puberty too early. And this could be a problem. If you can imagine being a 6-year-old having breasts or a boy with chin hair at 6, these are things that they would be teased about incessantly. So they do give a medicine, it's actually called Lupron, and it stops them from going through puberty too early. And it waits till the appropriate age, and then they'll stop the medicine and they go through puberty normally. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? Now, these hormones get confusing. We have pituitary, we have thyroid, we have parathyroid, we have adrenals, and there's all different things that they do. When we talk about thyroid, it's T3, T4, TSH. Those are the things we look at. Growth hormone, we normally look at that with the pituitary gland, with the anterior pituitary producing those hormones. And cortisol is your adrenals. That's your steroids, your endogenous steroids that you have. So these are the things you need to understand for this chapter about endocrines, okay? Where do they come from and what do they do? How can you monitor a child with hypo or hyperthyroidism? We do it every single time we see a child. Remember, hypothyroidism, when they're young, we worry about cognition. And then as they get older, with hypothyroidism, we worry about their growth. So why do you think we do a height and weight on every time we see a child? Whether it's in a doctor's office, whether it's in an ER or urgent care, we always do a height and weight. Well, yes, we want an accurate weight for medications, but we're seeing, are they growing the way that they should? And if they're not, then what's going on? Is it a thyroid problem? Or they're growing too much? Is it, again, a thyroid problem? Because gigantism is too much thyroid, okay? Or too much growth hormone. All of these things play into a picture. Height and weight tell a lot of things. What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Now, one of the things you need to know, and you learn it in med-surg, and I go over it in pediatrics, is your acid base. We have respiratory acidosis, alkalosis, and we have metabolic acidosis, alkalosis. Remember one thing about the body. The body tries to do the opposite of what's happening to them. When you have a diabetic child, their pH is usually less than 7. They're in acid, right? So they're metabolic acidosis. Kussmaul respiration mimics that deep breaths blowing off the acid, which is called respiratory alkalosis. Okay? So when you're looking at acid base, if you had this, why is the body doing that? It's the compensation. The body is neat. It tries to help itself, tries to fix itself. A multi. What would you see with a child with Cushing syndrome? This is an adrenal thing. This is usually when we give too many steroids or too high a dose for too long to an adult or a child. I call Cushing syndrome the Cush Pillsbury Doughboy. They get the big round face, they get hair, they get acne, they get the red. It's called ruddy, but it's these red cheeks that go on. Their arms and legs are thin, but their trunk, face, and neck are pudgy. They're fatty. And that's all Cushing syndrome. Remember, with Cushing syndrome, usually it's too much steroids that they've gotten. Usually we've given them, a medication order for it. Remember, you always have to taper it off. You cannot just stop steroids. They must be tapered off and lower the dose. A multi. You walk into a child's room, the fever is 104.6, and you see them having a seizure. What can you do? What would you do? Walk in a room, they're having a seizure, and they have a fever. At this point, does it matter that they have a fever? They have a seizure. What did I tell you need to do for a seizure? Well, we can't do anything. You can't put anything in their mouth. You can't open an airway, but turn them to the side. Make sure suction's at the bedside, right? You can check to make sure, kids put everything in the bed next to them. Make sure if there's stuff with sharp edges, get it out because they could be tonic clonic and they hurt. If you can get the side rails up, I use the blankets, the sheets, the pillows, all to pat those rims, and then the head down. So, and if you need help, always calling for help, monitoring again. What time did it start? What did it look like? Because you're going to have to document. The fever at this point is secondary. The first thing is seizure and protecting them, safety. An autoimmune disease of the thyroid gland. This is usually your young, like your older school age and young adolescent girls. We see this a lot. And because it's an autoimmune disease, surgery is not available for this. You can't take it out. You have to leave the thyroid gland there. It is called Hashimoto's disease. The thing with Hashimoto's, it's autoimmune. They're immunosuppressed, child or young adult, and they need good regulation of their thyroid medicine. Usually it's 2 different types that they're on and monitoring it very, very closely. Addison disease. Okay, this is adrenal, and this is when not enough. Cushing is too much steroids, right? Addison is not enough. So the adrenal gland, what does it produce? It produces cortisol and aldosterone. If you don't have enough with Addison disease, we're going to have to be given cortisol and aldosterone, knowing that with any of these immune type diseases, they at periods of stress and as they grow, they're going to need bigger doses of the medicine. So Addison, you need to give them something. Cushing's, you need to decrease it, take it away. And those usually steroids, cortisol, same thing. A multi, a ventricular peritoneal shunt. Our first question was about increased intracranial pressure. A lot of times that could be due to an extra fluid on the brain. Has to do with the way that it dumps down into the spinal column. There's some blockage and it just keeps up into the brain and it gets too much pressure up there. So what they do is we're seeing that fontanelle getting bigger. They're having that really high-pitched cry, right? We know something's happening and we find that the fluid is not moving. So we put this tube in, it goes up into the brain, comes behind the ear, and you're going to feel like a little pump. We do not touch that. That's only for neurosurgery. It goes down the front of their chest and into their abdomen. Therefore, ventricular is the fourth ventricle in the brain down to the peritoneum, and it just drips it off. What is our job with this? Well, intake, output, daily weights, looking fluids, right? But also measuring their head and their abdominal girths, making sure that it's, not increasing or decreasing, making sure that the numbers are maintaining, okay? A common side of Graves' disease includes blank or protrusion of the eyes. Now, Graves' disease is another word for hyperthyroid disease, right? Too much thyroid hormones being produced. And it's called exophthalmos. And ops is your eyes. And they actually do. They look like they're pushing out of them. There's these eye drop commercials on about them now, and this lady wearing the sunglasses, but it's very significant when you see it. A multi. Hypoparathyroidism has the symptoms of tetanic muscle contraction and what? Well, the parathyroid has nothing to do with thyroid hormones. What it has to do with is your calcium in your body. Think about muscle contractions. You have calcium and magnesium that always make muscles contract. If you don't have enough, it just sits there. The muscles don't contract. So you're going to see the weakness, right? And of course, it's going to be that low calcium levels. Hyper, you're going to be in spasm because those muscles are so tight and you have elevated calcium levels. So always remember that. Calcium, magnesium, we'll always talk about muscles, especially calcium. So parathyroid, think calcium. Think muscles. A multi. What are signs of hyperparathyroidism? Parathyroid, calcium, hyper, too much calcium. What does it happen? So it starts with too much calcium. It's the vomiting, confusion, and then the paresthesia of the extremities. And it's hypercalcinemia, okay? Too much calcium. What does the parathyroid hormone do? Remember, parathyroid's all about calcium, has nothing else. It's only about calcium levels, and calcium has to do with muscles and the way that they work. Remember, your heart is a muscle. Which of the following might be a cause of an adrenal crisis, also called an Addisonian crisis? Addisonian crisis. Syndrome is too much steroids in your body, and we need to slowly taper them off. So, one of the things that can cause an adrenal crisis is when you just stop them. You don't taper them and you just stop them. And it's actually an emergency and it's dangerous. And the way to treat it is to give steroids. So, abrupt withdrawal of steroids, we don't do that. Taper it. A multi. Cardinal sign of diabetes insipidus. Remember I told you diabetes insipidus and diabetes mellitus. What's diabetes insipidus all about? The posterior pituitary gland. What does the posterior pituitary gland worry about? Fluid balance. So which one of these would you pick? You wouldn't pick polyphagia. Excellent. Good. Only two of you did that. It is urinating and drinking. Excellent. And it's an increased urinary output. You're putting out urine like crazy. A multi. Congenital hypoplasia parent teaching should include, when you're not born with enough of your hormones, the Addison's disease, you don't have cortisol, you don't have aldosterone. And these children are born and we don't know if they're a boy or a girl. And I've actually in my career only seen one of them. And this little girl had a prominent clitoris and had testicles and had a vagina. Now, what they did was they went and did all sorts of hormonal testing and did ultrasounds. But the bottom line is, they had to like give the child, are you a boy or a girl? That's what they did it for. But this child will never have children and they will be needing cortisol and aldosterone replacements for life. And remember, as stress, they grow older, they're going to need increased dosages. So, I mean, I've seen one and it's difficult for a parent. So, did you have a boy or a girl? So, these parents need a lot of comfort. What causes type 1 diabetes? Too much chocolate. Now, I know you're going over diabetes, and I know you're going over, when we get to the point of DKA, diabetes ketoacidosis. So let me just try to describe diabetes to you easily. Well, we know that the pancreas secretes insulin, and insulin is what you need to take the sugar that we eat and to use it into the body. Well, and sugar cannot be digested. Sugar sits there and it just gets lost because nothing else digests it but insulin. So the body's not getting sugar. Yes, it's in the body, but it can't use it. So it says, there's fats and there's proteins. So it starts eating them and it starts getting what it needs by nutrition. But when it does that, the sugar's high in the body. That's why you have elevated blood sugars. And then the byproduct of this taking protein and fat and breaking it down is ketones. So you have ketonuria going on. So elevated blood sugars, a lot of ketones in there. pHs are low. And how do we treat this DKA? Well, it's the body saying, I need sugar. So we need to start an IV with a slow, continuous infusion of a regular insulin drip, monitoring carefully the blood sugars, usually at first every 15 minutes, making sure it comes down slowly. And of course, bolus of fluid because they're usually dehydrated when they come in, DKA. So that's DKA in a nutshell. Which statement about a pheochromocytoma is correct? This is an adrenal tumor. The one thing about it, it's sort of like that Wilms tumor. If you touch it, it's metastasized. But with a pheochromocytoma, you touch it and it secretes catecholamines, which means it elevates heart rate, blood pressures, and everything, sympathetic nervous system, up, excitability, okay? So it's hard actually to diagnose. Usually they'll go right to the heart, try to work it up. They can't find it. Then they think that you're just having stress, panic attacks. And then they finally figure out, do a CAT scan, and they find this tumor. And it's when they get rid of the tumor, everything's okay. But this is not all the time elevated blood pressure and heart rate. And what happens is it's like all of a sudden it secretes and everything goes up and then it stops. And then it could be once a day, twice a day, 10 times a day. It's all different. So this is a catecholamine, everything up, sympathetic, everything goes up, heart rate, blood pressure. A multi. Which action should the nurse implement in the care of a patient with a pheochromocytoma? So this patient's coming in and we finally figured out it's a pheochromocytoma. What are you going to be monitoring? What are you looking for? What did I tell you would see with a pheochromocytoma? You're going to see heart rate up, blood pressure up. Yes, yes, yes. Has nothing to do with glucosuria, has nothing to do with weight gain. It's all about speeding the body up, okay? And that's what you see. A multi. Nursing care of the unconscious child include, it could be due to many reasons. It could have been one of the kids who fell off the second story balcony, fell on their head, and they've got a head injury, right? They're unconscious. What is our biggest thing with these kids? It's all absolutely narrow checks, vital signs, because we can tell a lot just by the heart rate starts getting elevated. We know they're in pain. And then, of course, intake and output. The kid's unconscious. Usually there's a head problem. We don't want extra fluid in the head, which will exaggerate head injury, right? So very good. What might you suspect if a child feels jittery, sweaty, and dizzy? What does that sound like? This is probably hypoglycemia. Absolutely. That jittery, sweaty, dizzy. Absolutely. What an adult does, a kid does the same. Symptoms of diabetic ketoacidosis are remember, body doesn't like sugar. It can't digest it. It's going to eat fats and it's going to eat proteins. Byproducts are going to be ketones. And the one thing, because those blood glucose levels, I've seen them over 1,000 blood glucose levels. This fruity breath, it smells like you take a Tupperware container, put a fresh, ripe peach in it, and forget it for a month in the refrigerator. Go and open it, and that rotten sweet that you smell, that is what DKA is. And that absolutely describes it, okay? It is, it's DKA. And it's because of those blood sugars. They ooze sugar because they're not getting rid of it. And of course, the ketonuria. A multilect. An adolescent with a BMI above 95% has been urinating a lot. What test can you anticipate? What could this be? A BMI above 95, they're obese, right? But they're urinating a lot. What does urinating a lot mean? Well, if they're urinating a lot, you want to do a urine. Is it a urinary tract infection? Simple as that. Also, electrolytes actually should be there because urinating a lot, you're losing potassium. I didn't have that one checked. It could be diabetes, right? As part of it. Polyphagia, polyuria, polydipsia. You're eating, thirsty, and urinating a lot. This is the hemoglobin A1C. What do we want to see in children? Actually, they let you go to 7, where they call it diabetes with the hemoglobin A1C. We know we're pre-diabetic at 6, 6.5, absolutely diabetes in the adult, but it's 7 for children. Diabetic ketoacidosis is caused by what? So it's caused because the body can't get to the sugar. So it starts eating the other fuels, the fat and the proteins, and that's what kicks it all off. A multi. A child's admitted with blood sugars greater than 600, large ketones in the urine. What is your priority intervention? What do you do first? I mean, you're going to do all of these things except one. Number one priority is giving IV normal saline bolus. Get fluid in there, dilute that sugar. That's number one. And at the same time, you've called the pharmacy, sent up the order, and you're getting the medication for that regular insulin, slow, continuous drip. Now, then after that's all settled, we'll be getting the labs back and we'll be looking at electrolytes, especially the potassium. Sub-Q insulin at this stage, the kid's too critical. It's more that regular IV that we're going with. A diabetic child complains of feeling jittery. The blood sugar is 45. What's the best treatment for the child? Remember, when we treat low blood sugars, it's patient condition. This child's complaining of feeling jittery. So what would you do? We're going to feed them, right? Glass of orange juice, glass of milk, and that initial little bit of carb, and then get some protein in them. Like a turkey sandwich is always the other thing we used to always have on the unit for these children after they get some juice. Very good. Your patient has experienced a head injury. What would most concern you? Remember, head injury, swelling in the brain. What can it do? Almost anything, right? But what's the worst thing? It could be squishing against the pituitary gland and causing decreased urinary output. That's telling you there's a lot of swelling going on in that brain. Very good. A multi. How do you detect diabetic ketoacidosis? You know, most kids who come in with DKA, they're pale, they're very lethargic, they can hardly hold their heads up, and they're dehydrated. And within half hour, these kids are pink and talking again. Elevated blood sugars, ketones 4 plus, large, 4 plus glucose in it, dehydrated most of the time, but it's not necessarily the dehydration that detects the DKA. It's the sugars, the ketones, and the glucose. A multi. What would alert you that a child's head injury is deteriorating? A little bit of everything. They're confused, they're restless, you can't arouse them, and then the headache is getting worse. And a lot of times, like you'll even hear like with brain tumors, vomiting not related to eating and waking up with a headache, from your sleep. These things can happen also with a head injury too. Children with head problems tend to do the same thing. So that's what you would see. Head injuries. Usually that level of consciousness is getting worse. A child's been diagnosed with bacterial meningitis. What's the nursing priority of care? Remember, any child admitted with bacterial meningitis is going to be placed on 24-hour strict isolation until we get 24 hours of antibiotics in them, right? Bacterial is antibiotics. There's viral meningitis, and we do symptomatic. We don't give antibiotics because it's viral. It's not going to do anything. We give fluids, ibuprofen, acetaminophen, rest. Bacterial, all of that, plus we're going to give antibiotics. And then after 24 hours, they can come off isolation. What is the primary cause of injury associated with submersion? Drowning. I live in South Florida. I've seen a few submersions. The problem with drowning is you don't necessarily see everything that's going to happen in the first visit that you see them. They're usually admitted because you can see 72 hours later, all of a sudden they go into stress. And it's because their lungs filled up with fluid and they became hypoxic. That is why you get these damage to the lungs, and why up to 72 hours later you can go into respiratory distress. And last question, a multi. Which CSF lab results correlate with bacterial meningitis? No, I worked in the ER a lot, right? I've got a lot of kids coming in that they're meningitis. Well, bacterial or viral? Bacterial, I want to get those antibiotics in quick. So I'd always be looking. I want to know what that CSF fluid looks like. Well, if it's clear, it's viral. If it's cloudy, it's going to be bacterial. And bacteria loves sugar, so it eats it. So your blood sugar is low, okay? And proteins, they don't like, so they keep it there. So low glucose, elevated proteins, and then you're going to see white blood cells in there. That's what makes that fluid look cloudy. Good job, guys. Katia, number 3. Good job, Katia. Corey, good job, Corey. Whoop, whoop, whoop. Number 1. Ryan, good job, Ryan. Peggy and Chris. So this is my class for today. I will be sending you the recording myself, so you don't have to wait for Professor Pace Chismar. I'm going to do that for you. I do have access to all of the shells, and I'll be, reposting again the PowerPoint that goes with it. Does anybody have any questions about anything? I appreciate all your patience. And in this time, if you can't get a hold of Professor Pace Chismar, get a hold of me. I'm going to answer you. Okay? So if you need anything, let me know. I'm always here. Just because I'm not your professor doesn't mean I'm not here for you. Remember, I'm lead pediatric professor, so I'm here for all of you. So nice meeting you all. Thank you for your patience for today. Grades will be out either late Friday night or early Saturday morning. Okay? So
Thank you.
we will let you know.
Thank
Thanks,
you. Have a
guys.
good night.
Good night, guys. Thank you.